And welcome to tonight's session, being brought to you by the members of the AO North America Hand Education Committee in our series on complications in upper limb surgery. Tonight's session is dedicated to complications after forearm injury. As you are well aware by now, after 2 years, that the Hand Education Committee has made every effort to be very inclusive, not only in terms of our diversity, but also in terms of involving hand therapy as well as our colleagues from trauma. Today's session hits the mark on all of the above. And we have a spectacular faculty being moderated by Dr. Christina Bolton from Tucson. And I'm going to let her take it from here and make the introductions. And it's going to be a wonderful session. Christina, all yours.
Awesome. Thank you. Welcome, everybody. We're excited that you're here. Thank you, Chai, for your introduction. And then this is me. I'm an orthopedic trauma surgeon in Tucson, Arizona. So for my hand colleagues who don't know me and wondering what some trauma person is doing moderating the session, I think it'll make a little bit more sense in a second. So we have a faculty that is sort of half trauma. Tony McLaurin and Jennifer Hagen are two of my trauma colleagues. And then we have our other half of the faculty, which is Anne Willett and John Capo, an all-star group all around. And our second two are hand faculty. So as everybody knows, the forearm is kind of an area of overlap in terms of who takes care of what. I like to think of myself as the real complication generator. So I sort of feel like most of the stuff we're going to be talking about today is probably coming right out of my practice and probably into your practice. So just quickly, no big disclosures. Here's everybody's relevant information. This is our lineup for tonight. We'll start and talk a little bit about non-union and then malunion, delayed compartment syndrome, and then longitudinal instability. There'll be a little bit of time after each talk for questions as well as at the end. Here is our content validation statement. And our Zoom etiquette, I think most everybody's familiar with this now, but everybody's microphones and cameras will be off, and there's a Q&A box. If you have questions, send them to us and we'll be reading them as the presentations are occurring. Here are our learner objectives for tonight. And then this session, tonight's session is number 5 of 7 in our complication series from the AO Trauma and Hand North America group. And so there's 2 more sessions after this week. So if this week is something that is beneficial to you, then sign in next week and the week after for more information. There's also some outstanding upcoming AO hand courses listed here and here. And then I also want to put in a plug for our YouTube channel, AO Hand North America. And we have an AO Trauma Hand North America series podcast. And there's the link below there. So just to plant the seed, this is a patient that came into my clinic last year, actually. Someone I'd never seen before, a 36-year-old incarcerated gentleman who just came in with wrist pain. That's all he complained of. And these are the x-rays that we obtained in our clinic. He said his wrist pain has been gradually getting worse over the last 6 months since he had a surgery. And that's kind of the extent of the history that we get, really. It doesn't actually bother him how crooked his arm is. It just bothers him that it hurts. So this is sort of a whole bag of worms, but I want you to think about how you would approach this and some of what are the challenges that you might encounter as we start off with Dr. McLaurin, and she will share her talk here to start with non-union.
Okay, so hopefully this is showing up correctly. And sorry, I am Tony McLaurin, and I'm trying not to go forward. There we go. And I also am a traumatologist. So full disclosure, so some of these things that you see that I'm trying to reconstruct, if you're a hand surgeon, just kind of, put your hands over your eyes if you're not impressed. But I generate plenty of my own complications, which I discovered when I was putting this case together. This talk together. So I have no disclosures. And these are just the learning objectives to define non-union, talk about the different types. and how you evaluate and work them up, and then understand the indications and surgical techniques for managing it. So the thing we need to talk about with the non-union is when the definition is when the normal biological healing processes of bones cease. It used to be that we said it was a failure of the fracture to unite within 6 to 9 months, or failure, or not, that was a delayed union. Non-union was failure to unite after 9 months. And some insurance companies still use that definition, but that's really not what we think about anymore. We now call it failure of progression of healing, or no change in serial x-rays over 3 months. And when you feel like additional intervention is going to be required to get this to heal. A delayed union is just that the speed of the fracture healing is slower than anticipated. So there's no actual timeline for it, but more what you're seeing happening. So for your treatment strategies, the first thing you have to do is admit to yourself the patient has a non-union. It's really difficult for us to, as surgeons, to look at x-rays and admit that they're not going the way that we would like them to. But then when they finally look like the one on the right, you realize that you got to admit that all is not well. Then you have to figure out, why is this happening if you can. There's certainly going to be host factors that we can't change, some local factors that you may or may not be able to change. And then again, we have to admit that there are some surgeon factors. So you need to understand the quote unquote personality of the non-union and then correct whatever the problem is. So of course we have the host factors, the usual suspects, diabetes, any metabolic issues, NSAIDs, maybe not, probably not as big a deal as we think they are. And so those, excuse me, those are things that we need to think about that we can't really change. Also local factors, nothing we can do about a soft tissue injury, what the vascular supply is of the local tissue, if there's an infection, interposed tissue, but we can do things about inadequate reduction or fixation, which results in excessive fracture gap motion. Again, we can't control the open fractures, high energy injuries, comminution, bone loss, or poor bone contact, but all of those go under the severity of injury and can certainly affect what is going to happen. But we can control inadequate debridement of the devitalized soft tissues, as I mentioned before, inadequate fixation, or just poor surgical technique or decision-making in your initial stabilization and treatment of fractures. And here is a forearm fixed with 2 1/3 tubular plates, which I guess only 1 1/3 tubular on the radius. And I literally just walked into an OR the other day, and they were about to put a tiny little plate on a forearm. And I was like, what are you doing? We've already been through this. This is what happens when you get old, you know, all this stuff. You already saw the failures. So we do have to admit that sometimes we are the severity of the injury. And then when you classify the non-unions, you have to recognize what it is based on its vascularity, viability, which is determined by the vascularity, and its stability. And we're all familiar with this, the hypertrophic non-union or the elephant's foot. This is an issue of good biology, but bad stability. So you need to do something about that. Oligotrophic is always a little bit hard for me to really define. It does imply adequate vascularity. The bone ends are viable, but it's so-so biology. So you have the good vascularity and your stability is okay, but not great. And then in an atrophic, you just have poor vascularity. And it doesn't matter if your stability is great or not, nothing is happening. So this is bad biology and bad stability. And so when you go to diagnoses, obviously clinically, pain and motion are big issues. Radiographically, plain x-rays you always start. CT, MRI may be helpful depending on what else you're looking for. And you got to get labs. You always have to think about infection labs, including CBC, ESR, CRP, which all can be negative in the face of osteomyelitis. And then if that's not, if you're not finding any other cause, you need a metabolic workup. So as I said, these can all be negative in the face of osteomyelitis, but if you combine them all, 3 positive tests, the predictive value of infection is 100% if all of these are positive. If 2 out of 3 are positive, then that gives you about a 50-50 chance that you're looking at infection. And if all 3 are negative, you're about 80% sure that you're not dealing with an infection. So in combination, that can be very helpful. Again, as I mentioned, you need to figure out, why did this happen? Determine the mechanism of failure. Was it mechanical? Was it biological? Or was it a combination of both? And then you need to optimize your results by recreating those things that are causing it, adequate stability and adequate biology, both in the bone and the soft tissue. And you need to get the patient moving. You could make the most beautiful, new bone from your non-union repair, but if the patient is stiff and non-functional, that doesn't help you. So this is about all non-unions. So what's so different about the forearm? The forearm, the entire forearm is a joint. Then you have bows in both of the bones, which will get talked about in later talks as well. And the axis of rotation is from the radial head to the ulnar styloid. So the radius rotates around the ulna. So this is a very different part of the body or different area than anything else in the body. There are a lot of articulations. So most people consider what makes up the joint of the forearm would be the DRUJ, the PRUJ, and the interosseous membrane, but there are articulations at the wrist and at the elbow as well. Non-unions occur in about 2 to 10% of all forearm fractures, and I was happy to see that they're frequently associated with infection because every single one that I have is an infected non-union, and also surrounding soft tissue loss. There's just not a huge soft tissue envelope around the forearm, and so that creates a poor environment for bone healing. The problem is that if you have a non-union, the dysfunction extends from your elbow to your wrist, and it can cause problems in placing your hand, your ability to place your hand in space. So you have to recreate and restore all of the articulations for successful management of a non-union. So I'm putting this up here, even though this is not a distal radius talk, and this originally obviously is distal radius plate on here, but this is functioning more like a forearm problem. This is just an example of something that was transferred in from an outside hospital. I'm happy to say I did not do this surgery, but you can see what's happening looking at the wrist. But if you look at the entire forearm, you can see how the articulations are really massively affected by this problem at the distal aspect of the shaft. So this is really more of a distal shaft fracture than what you would consider with a distal radius fracture. And so it was revised, and my x-rays are all terrible, and you'll hear about terrible x-rays in the next talk, but you get what you get. But the important thing when you're doing this, because of all these different articulations and the bows, is that you need to get contralateral views. Unfortunately, these were the contralateral views of this patient who had this strange DRUJ screw fixation on the other side, and obviously had a distal radius injury. So this was not helpful at all. So whatever I did was still going to be way better than what they had. So here's just a few examples. A 36-year-old right-hand dominant male struck in the arm by a bat 2 months prior to presentation. He didn't seek care because he felt like he needed to keep going to work to take care of his kids. And then unfortunately, he subsequently got arrested. And since I work at the hospital that has a jail in it and that all of the patients at Rikers Island come to, he was ultimately brought to the hospital because of this obvious deformity of his wrist. And so here are just wrist x-rays showing you, and you can see the huge prominence of the ulna there. And then here, he did have a normal wrist on the other side. And this is absolutely essential to get the normal side, and see the x-ray tech was a little bit confused, which was which side as well. And so this was just a pretty straightforward compression plating with DRUJ fixation. Is it fully out to length? I don't think so, but I tried really hard. And the reason you see a gap, you say, well, it's compression plating. Why is there a gap? Because this is not a fresh fracture. So you're going to see some resorption in the bone ends. You're going to see some edges that don't quite come together, but this is pretty good. This easily goes for compression plating. The goal was to restore all of the articulations. As I said, I think it's still a little short, but again, these are not great x-rays. The DRUJ is not congruent, but he did actually have good function full pronation, supination in the OR before we pinned the DRUJ, and showed up 6 weeks later looking like this. The pins were pulled, and then he was lost to follow-up, which is a recurring theme in most of my presentations here. Here's a 30-year-old man, fell off a motorcycle and then was hit by a car, so having a very bad day. This was an open fracture. He also had a left paralunate dislocation, acute carpal tunnel, and then unrelated to his upper extremity, a transverse posterior wall acetabular fracture. So pretty straightforward, IND, ORAF. I would argue that the radial bow was not restored, and I can't blame this on anyone except me because I was the one who was there. But, you know, otherwise, overall, it looked pretty good, looked like a good compression plating. 3 days later, he went back to the OR to get his perilunate fixed. And when they took his splint off, pus rolled out of his arm. And so we had to IND it, couldn't get the volar wound closed. Ultimately, everything got closed. All his wounds got treated. 2 months later, little bit suspicious. This is not looking great, but the hardware all still looks intact. Everything's looking pretty good. And then 8 months later, he comes back looking like this. So this is clearly an infected atrophic non-union. You see the hardware's failing, screws are falling out, bone looks terrible. There is no evidence of healing here. And so we did an aggressive debridement and then Sequelae. So we resected all of that terrible looking bone, more so on the ulna than the radius. Again, I would say I didn't get enough radial bow. This becomes a lot harder when you're spanning these large segments, especially right through the area where the bow is. But he did have full forearm rotation in the OR. And then 6 weeks later, underwent bone grafting with RIA to fill in that giant defect in his ulna. And then if you take this to its most extreme, again, same thing, persistent draining sinus. So I thought, it's going to be a little bit of an ulnar debridement. And by the time we finished, it was this massive gap in here. And so again, Sequelae, and she actually underwent a free tissue transfer, free fibula transfer with a skin paddle. And this is what she looked like ultimately. And I just very coincidentally, she just showed up last week for follow-up and she's incorporating her free fibula. So you see that's a huge area that's being incorporated right there, but it's compressed on both sides and looking pretty good there. So again, restoring every single articulation in the arm, restoring the bow of both the radius and the ulna. And then, so this is just a good sort of summary of how to manage these defects. So if you have an atrophic non-union, but the bone ends are close, you can do plating and bone grafting of it. If you're starting to get more of a gap, you can consider an intercalary segment, a non-vascularized intercalary segment, and with plating and compress that segment inside or in between the two ends. If you have a hypertrophic non-union, all you got to do with that is just compression plate it. And then if you have a bigger segment, you may want to consider the free fibula, as I just demonstrated right there. So what you want to do is achieve your stable fixation that allows motion at the joints above and below the non-union. And in this case, of course, including the whole forearm, which is a joint itself, you need a healthy, well-vascularized soft tissue envelope in order to make this happen. And you really need to pay in the forearm meticulous attention to restoring all the joints in the forearm and the bows in both the radius and the ulna. And I just want to show this case real quick as just an example of the principles not being followed. This is a 26-year-old right-hand dominant helmeted bicyclist struck by a motor vehicle. He had this open forearm fracture. So, looks pretty standard. Compression plating, looks okay, looks fine, don't expect anything bad. Shows up a year later complaining of pain, looking like this. Clearly an infected non-union. Taken back to the operating room. And so he underwent this revision ORF non-union repair with antibiotic plates. But if you look, the terrible looking bone was not resected. The fixation is not at all stable. It's still sitting on top of some of this bone that troughed out here and should be much more proximal. Neither the radial bow has been restored. The ulnar bow is not restored. This is overbowed in the lateral x-rays. So none of this is good, and I'm happy to report that I did not actually do this case, but was able to find it. And then 4 weeks later, he shows up, and this is what his x-rays look like, and you can see screws are already starting to back out. Things are not looking good. So the problems, as I mentioned, were the principles that I just discussed were not followed. So you assume this is probably doomed to failure, but lucky for us, he was lost to follow-up. So that's what I got on the non-unions right there. So thank you.
Awesome. Thank you, Tony. I feel like it's just like your kids, right? It's so much easier to recognize a non-union in someone else's patient. You're like, oh, I didn't do this surgery. That looks like a non-union.
Yeah.
When it's your own patient, you're like, wait a minute, that looks perfect. What are you talking about? And so one quick question while Jen loads up her images. She's going to talk to us about malunion, which is, closely related, maybe an even worse problem or a harder one to fix. But one quick question for you, Tony, just actually for me. What do you do with patients who are smokers? Do you make them quit before you deal with their non-union? Do you test them, or do you just sort of go forth and conquer?
Yeah. I used to try to test them. First of all, it's really hard to get urine nicotine or any sort of test. There's something else, I can't remember what it is, that you can get in the hospital, but it's really hard to get it at a lot of hospitals. And I just kind of gave up. And basically, if I walk in the room and I choke on the smell of smoke when I walk in the exam room, I tell them, either you're smoking or the person who came with you is smoking, and that has to at least get better before I treat you. But you think about a lot of non-union work was done in Europe, and especially Italy. They smoke like fiends over there, so it's clearly it plays a role, but I think there are a lot of other factors as well. And it may just be that there's some linkage between that and, malnutrition, poor diet, things like that. But, I think it's very hard to get, if people smoke, it's hard to get them to stop smoking.
Yeah, I agree. It's hard to get my patients to do anything.
Yeah,
but Jen Hagen is going to talk just a little bit more now about forearm malunion. So
perfect. Thank you. Good evening, guys. As she said, I'm Jen Hagen, so I'm also one of the traumatologists on the call tonight. I'm going to dovetail a little bit on what Dr. McLaurin talked about. I also make no money for anything. So we're going to talk a lot about the imaging and appropriate imaging and paying more close attention to the rotation of the forearm when you're looking at your x-rays. We're going to talk a little bit more detail about the bow that Dr. McLaurin alluded to, both the radius and the ulna, and kind of do a step-by-step plan for deformity correction. So we're also going to discuss one case. So this is a 49-year-old male. He had bilateral open both forearm fractures. We are only going to discuss the right for this case. He was treated at an outside hospital. He had fasciotomies. They fixed him. He then subsequently passed out. They took all the hardware out, put him in an X-Fix, and then spent quite a bit of time before he got to us. So he came to us at 3 months. So he's been in this frame for 3 months now, sitting just like this. His incisions have healed, thankfully, and his pin sites are clean. He's got some neuropraxia, some weak nerves in his forearm, and obviously has a lot of pain. So looking at this is a hot mess, right? But we're going to break it down step by step. What are our goals? So I already talked about we need length, alignment, and rotation of both bones. We're going to talk about the bows in both planes, the coronal and the sagittal plane. We'll talk a little bit about DRUJ, although there are all other risk talks coming forward, and Dr. McLaurin's already talked to you about taking care of the bony defects. So as we talked about the forearm, unlike other diaphyseal bones, we think about the forearm in itself as a joint. The radius is bowed and the ulna is bowed, and the radius rotates over the ulna. That bow is necessary to have a full arc of supination and pronation. So the entire length, alignment, and rotation need to be anatomic, not just fine. And the functional arc of supination, pronation, we think is about 50-50, just so that's your goal to get people back to. And something that I found when I was making this talk, which I don't really think about, the hand guys probably do more than I do, but it's an important thing, important point is not only does the radius rotate around the ulna, as it rotates and translates, it shortens and lengthens relative to the ulna. So your visualization of the DRUJ on x-ray will change depending on the rotation of the forearm. So it's really important to know what position the arm is in when you're trying to assess your DRUJ, not just with the clinical shuck test. So what is the coronal bow of the radius? So first thing is you have to figure out how to look at it. So the x-ray on the left is a good AP, and we know it's a good AP because we're seeing an AP view of the elbow and an AP view of the wrist. So the patient's arm is supinated and the elbow is extended and they're shooting from top down. We have a bad AP. So the x-ray on the right is a contralateral arm of our patient, and it's an AP of the wrist, but then if you look at the elbow, it's a lateral of the elbow. So the way that they got this is the elbow is flexed and the arm is held in neutral and they're just shooting across the table. And the reason that's a problem is if you're trying to assess the bow and the rotation of the radius, you can't see the radial tuberosity. So a good way to judge your rotation intraoperatively, if you don't know that you've got the rotation of the radius right, you want to make sure that the styloid is 180 degrees from the tuberosity. So you can ignore everything in between and just make sure that those things are opposed to each other. But the only way that you're going to be able to see that is if you have a good AP of the forearm. Then the position of the bow has actually been very scientifically described, and I don't know that you ever get to make this measurement in the operating room, but in general, just so you have some idea, if you were to draw a line from the end of the radius to the tuberosity, the bow happens just past the midline if you're going from proximal to distal. So the maximum bow is roughly around 60%. So if you were to put the radius right in half, it's just 10% past that. So the bow is just slightly distal, and it's about 1.3 centimeters. Again, that's not a measurement you would ever take intraoperatively, but just having a rough idea of how much the average bow is. That's on the coronal plane. So there's also a bow on the sagittal plane. So imaging on the lateral is also very important. So the top x-ray is a good lateral. It's a lateral of the elbow and a lateral of both the radius and the ulna without any rotation in the forearm. We have a bad lateral. Again, this is a contralateral arm. So we have a lateral of the wrist, but then we have an AP of the elbow, right? So that the arm is sitting in neutral and they've rotated it and then just shot down like this. So that again, doesn't show the position of the distal radial ulnar joint very well at all. So the bow and the coronal or in the sagittal plane for the radius actually happens just proximal to the midline. So if you put these two drawings together, and this was also something that was interesting to me when I put this together, I kind of assumed they are in the same spot. They're not. It's actually the coronal plane bow is slightly distal to midline. And then the sagittal plane bow is slightly proximal to midline. And the bow on the lateral is not nearly as dramatic as it is on the coronal. And this paper that's highlighted in the bottom is actually a fantastic paper that came out of Cleveland. That's where these cadaveric pictures came from, where they kind of quantified this anatomic relationship. And I think over 400 specimens. It's really quite good. So moving on to the ulna. You know, I feel like when I was a resident, I was always taught that the ulna is straight. It's not. It's straight for kind of the distal 2/3 of it, but the proximal bend of the ulna is very, 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 very highly variable, where in the radius is a little bit more standardized. So in general, most patients have an apex dorsal angulation in the ulna, but not 100%. And they have a slightly varus bend to it in the proximal aspect too. So if you get a good AP of the forearm, you can see that the ulna actually tends to bow a little bit close to the radius proximal and then fans out a little bit as you get distal. So when in doubt, if possible, image the contralateral arm. So again, DRUJ, we'll talk more about the wrist. So the image on the left is the malunited patient that we're looking at. The image on the right is their actual contralateral DRUJ, knowing that they also had a fracture there. So if you look at them, they're relatively ulnar neutral. We have ulnar positivity on the side that we want to fix. And then when you look at them on the lateral, again, obviously we've got some pretty substantial posterior translation of the ulna. So if you want to think about how to plan it, you just kind of go down stepwise, like all the things we need to correct. So we know that we need to correct the radius and the coronal and the sagittal bow. And we probably need to look at rotation because we can't judge the rotation on our imaging. We also need to correct the ulna and the coronal and the sagittal bow. And then we want to pay some attention to the DRUJ when we're finished to make sure that we're ulnar neutral if possible and correct that dorsal translation. So this is the finished product, still with crappy x-rays, unfortunately. So how did we do? If you're looking at what we're calling the AP, which is the image in the middle, we do have some radial bow in the coronal plane. Hard to judge the rotation still, right? Because we don't have a good AP of the forearm, so I can't really see the tuberosity very well, but we've got a decent amount of bow there. On the lateral view, it's very, very difficult to tell, right? We can see that there is a bow, presumably it's in the correct direction, but that one's very difficult to assess. Now, looking at the ulna, on what looks like a lateral of the ulna, that portion of the ulna is straight, and that part should be straight. So that looks pretty good, and it looks like the bony defect is healed in. Again, on the version of the AP, or whatever we want to call that image all the way to the right, it looks like there is some bowing radially, which is what we want. How much? Very hard to tell. And then the DRUJ is almost uninterpretable. So clinically, this patient, after they had healed everything up, was locked in neutral. They didn't have any supination. They were able to pronate to 60, which is actually quite good. Their elbow did move for having been in X-fix for 3 months. So they had range of motion from 20 to 90. They had pretty good wrist range of motion without pain, and their nerve function actually returned. So despite a pretty poor start, we ended up with a pretty good outcome, even without perfect correction of all of the malunion. But to sum up, the devil is in the details, right? With any malunion, imaging, good imaging is invaluable, especially for this very, very complex constellation of joints. So do not rotate the forearm when you're obtaining AP and lateral radiographs. Instruct your X-ray techs to do this. If you're taking X-rays in the operating room, resist the urge to rotate the forearm because it changes the relationships of the bones so much it can be very difficult to interpret. You need to pay attention to both bows of both bones, and when in doubt, image the contralateral side. And any type of malunion, just go stepwise. It can be a very complex problem, and just break it down to single planar deformities and then sum them all up in the end. Thank you.
Awesome. Thanks, Jen. I love your malunion correction. I wish my malunion correction at the end here looks anything like that, but we'll see. So that was awesome. And hopefully everybody got a chance to see that link. Jen can put the link for that the paper with the cadaveric studies into the Q&A for you guys. So if anybody didn't get a chance to write that down when it was up there, it's actually, I've seen that paper too, and it's amazing. So Dr. Willette is going to go next, and she's going to talk to us a little bit about compartment syndromes or maybe compartment syndrome light that affects patients long-term. And a lot of those patients are the patients we're talking about right now who have severe injuries and crushes to their forearm, and kind of how you can go forth and take their nerve symptoms away over time and figure out things other than just the bones that are affecting their function and their pain.
Forearm compartment syndromes. And we're going to fly through most of this because most of you know acute compartment syndromes. But you know that if you will release many times just the volar side, you will end up releasing the dorsal side as well. And with acute compartment syndromes, it's pretty easy because you've got a lot of pain, you've got increased pressure, swelling that goes on to muscle necrosis. I'm not going to spend too much time on this because you all know it, but the causes are varied. And you'll notice all those causes are sitting there in your malunion, non-union. These are the complicated cases that end up with these compartment syndromes. And so it's blast injuries, burns, but even a cast, all kinds of different things, spider bites, snake bites, et cetera, can give you a compartment syndrome. The mechanism of raised tissue pressure leads to a compromised perfusion. So you're going to get muscles that aren't going to be as strong. When it's acute, obviously they're in extreme pain and just a stretch test, and you're diminishing blood flow, but you can do it in a very kind of chronic subacute way. And particularly obtunded patients. And again, the non-union, malunion patients, a lot of them were in an ICU for a couple of months, just trying to struggle to live. And when you have those situations, many of these things go unrecognized. And particularly like with head trauma and pressure from infusions and that kind of thing, and particularly in critically ill patients, the nerves are part of the problem. So you've got multiple areas. And so this, with the nerves, you now have epineurium, perineurium, endoneurium. Each one of these areas can create an area of compartment syndrome. Fortunately, for the most part, it's very rare that you have to release any of this, and usually just releasing the epineurium is sufficient. That's particularly true in like gunshot wounds. You have mechanical injuries, compression, traction, laceration, gunshot wounds, and then the secondary injuries, which is why you can get this delayed compartment syndrome in the face of the non-union malunion that also happens to be infected, which is giving you scar, callus. You can get heterotopic bone with these injuries, and then the ischemia on top of that. So the response to injury of a nerve, and again, this is much of the stuff you already know, but it's a limited repertoire that responses of nerves to nerve injury. So mild, you'll get a Schwann cell myelin sheath, focal demyelination, which, the cells can actually remyelinate and heal that. Severe injuries is where you get axonal degeneration. And then the question is how severe and can it actually heal itself? So with axonal injuries, you get Wallerian degeneration. The distal segments do get metabolic support, but the degenerating axons beyond the point of injury then have to re-heal themselves. This is a gunshot wound, and this is a histologic slide of one, and you can see that the myelin gets injected into the axon. And so now your body has to clean that up in addition to remaking the Schwann cells and the insulation around this. So if you get a chronic compression, you have ischemia and mechanical compression. It only takes 30 millimeters of mercury. So you can imagine if you've got a non-union malunion, it's creating swelling, it's creating scar tissue, it's tightening down compartments, and that's enough to diminish intraneural blood flow and axonal transport. And so you get a progressive axonal loss and fibrosis, and the damage can be permanent if you just leave it. And you get microcirculation effects with increased permeability and edema, increased endoneurial fluid pressure, and then you get this subperineural demyelination. So the other problem is compressed nerves also have a lower threshold to responding and being injured by mechanical pressure. So you've already got a situation where you've got these tight compartments, the previous injury. Now you add even more insult to it, and you're going to really diminish your nerve function. Provocative tests are really good for producing paresthesias and dysesthesias, and use those. So if you have a suspected compartment syndrome, again, in awake alert patients, you monitor them closely, but we all know there's a huge argument about, well, what pressure? Can you use pressures as a demarcation line? Not really. You're using clinical and pressure, and then doing fasciotomies, final wound closures, or allowing the wounds to heal secondarily. You can do that. Volar Approach is the best start for the forearm. And I usually will put these kind of to the side, not so much up the center of the arm, because you can still get over to the median and radial artery, median nerve and radial artery, the ulnar nerve and artery, releasing all these compartments and get down to the interosseous membrane, because you want to make sure you've decompressed all these different muscle compartments. Compartment syndrome sequelae, Volkman's ischemic contracture. We always think of that as a complete dead endpoint, but actually there's many grades of it. And so again, don't put your blinders on and think, well, it's all dead and there's nothing else to do. Particularly if there's persistent hyposthesias or dysesthesias, motor weakness, but you still have motor involved, infection, amputation, myoglobinuric renal failure. You can get that as the muscle is dying, but of course that tends to be more acute in the phenomenons. So for this patient, they lay on their arm for 24 hours, secondary to a drug overdose, developed Volkman's contracture, but we freed everything up, did a gracilis muscle transfer to restore his finger motion, and he still was able to function well enough, even though he had limited extension. And so don't give up on people. We collected patient data on 40 patients, and this encompasses the whole arm, both shoulder down to forearm. The average age was 53, and handedness predominantly right, but the affected hand sometimes, and 6 of them was bilateral. Average symptoms were going on for 3 years. So it really does take people a year to a year and a half to come in to see you. And the affected hand, same as the dominant hand in 19 cases. So that is your leading edge. We looked at nerve conduction velocities. So the normal nerve conduction velocities are in this gray zone. So they were all diminished preoperatively, both at the median nerve, at the elbow, at the wrist, ulnar nerve at the wrist, below the elbow and above the elbow. So you could see all of these are just sitting at slightly lower levels, but enough that it's affecting them. And so again, nerve conduction, sensory velocities, all diminished, median, ulnar. And so the underlying conditions, we also looked at that: diabetes, neuropathy, smokers. So they're all in here. And then, 14 of them didn't have pain management. Everybody else, though, did. So there's a significant number of people who are needing pain management for dealing with these things. So the medical history, the trigger for the onset, sometimes it just be, elective surgery. Other cases, it's a gradual onset, particularly if they've got diabetes involved. But falls, motor vehicle accidents, gunshot wounds, crush, the whole gamut of everything, repetitive stress. And so we looked at pain scales. The pre-op pain scale was above 3 on the VAS pain scale, but by 3 months post-op, they dropped to around 2, and then they begin to creep back up. And again, some of this is just scar and that kind of thing. But if you look at their Durkin's test, they really diminished the number of positive people with Durkin's, same with their Tonells, and same with the forearm compression test dropped, but it's still in there. It's still about, in terms of pre-op, positive, almost the same post-op in the forearm. And so their Semmes-Weinstein testing improved, and we had 3 patients that improved 3 grades, 3 patients that improved 2, 9 that did 1, and then green and all. And then we had another 6 that there was no change. So sometimes you're still there too late. Thenar atrophy, preoperatively, significant amount, and that drops dramatically. So the muscle appears to come back easier sometimes than the sensation. And thumb abduction improved as well. And MP joint flexion extension all improves, as well as elbow flexion extension improving, and finger abduction is about the same, but it did improve. So one quick case study, 57-year-old female, right hand dominant, hypertension, hypothyroid, and asthma with a right elbow fracture at 13 years old. She'd had ulnar nerve transpositions in 69 and 70. Most of her symptoms resolved, but became symptomatic again in 2007, had another ulnar nerve transposition, but it did not resolve her symptoms. And so she had some botulinum injections, multiple nerve blocks, did not relieve her flexed arm posture. She had another ulnar nerve release with scar tissue excision, and still presented with pain, et cetera, and in the ring and the small finger, cramping in her intrinsics, and weakness in her right hand. So you looked at her exam, and mainly the carpal tunnel, median nerve, as well as the intrinsics were the main issues. And so looking at Semmes-Weinstein testing, she was blue in the ring and small, index and the middle finger were green, but the thumb was blue. And then just looking at her median nerve compression was positive, and Guillen's canal was positive. So again, looking at her nerve tests, mainly the ulnar nerve was the main problem. And her median nerve actually appears pretty good in all of this. And her conduction velocities across the ulnar nerve at the elbow and above the elbow were part of the issue. So we decided to go ahead and redo everything one more time, since she was losing sensation, losing motor, also releasing the median nerve and the antebercutaneous. And we also released her carpal tunnel. And we found that in the end, she got all of her sensation back, and her thumb abduction improved. Her finger adduction was still weak, but the pain resolved. And so this was huge for her. And when we went in there, we found that she really still had a very mild Volkman's ischemic contracture. So what we did was really release all those compartments into the forearm, and that dramatically improved her. So the bottom line is, don't give up. These long-term compartment syndromes are there. But for all you trauma surgeons and all of us who, we're doing trauma at level 1 centers, release everything. Release it all there while you're doing your initial fixation. Don't be afraid to release the ulnar nerve at the elbow and all these kinds of things. But in the end, don't be afraid to go back. And the clinical findings trump the EMG nerve conduction findings. So don't use your EMG as a gold standard. It's really the clinical exam. Thank you.
Awesome. Thank you so much, Anne. And as John is loading his talk up, I just have a quick question for you regarding timing of releases in someone who is having a late surgery for a non-union or a malunion. Should that timing be simultaneous? Meaning, would you go in and do the nerve releases at the same time as the malunion correction, or you would stage them separately in case there were any other issues that went on?
All right. So with that, I mean, I actually do have a number of these cases. And if they have severe nerve deficits, so you're dealing with muscle strengths of 3/5 or less, and they're clearly nerves that are in the compartments, I'll get nerve conductions to localize as best I can where all that entrapment is. But if they're missing muscle and they're going to require a big reconstruction, I say do the nerve releases first, because we need muscle to be putting force across your bone in order to get your bone to heal. And if we try and do the releases and the reconstruction of your bones, of your distal radial ulnar joint, of your radial head at the elbow, it's too much. It's too much to get all of that done at the same time. So I'll actually release them, and also because they're in pain. So we'll get rid of the pain. Then we go after the function. So I'll do that. I'll stage it, usually about 3 to 6 months after the initial release. Then we'll do the other. And they're still very happy, and things go very well doing that. So staging it that way.
Perfect, thank you. So I think if you stop sharing your screen, John will be able to set up, and we'll be able to move on with longitudinal instability and Essex Lopresti.
How is that? Can you see me?
It looks beautiful.
Awesome. Great. Well, hello, everybody. I'm John Capo from New Jersey, and I'm kind of a hand guy and trauma and, all micro and flaps and all that stuff, but good to be here. This is a complex topic. So I'm going to talk about Essex Lopresti, and it's obvious, but there's some, all right, there we go. There's my disclosures. There's some subtleties to it. Can I get this? I just want to move this. All right, perfect. Again. Okay, so this is really crucial. The forearm axis, and we've talked about it a couple of times, but the forearm bone, or the bones in the forearm are they act as a joint, and it's different. Pediatrics is different than in adults, but it's really critical to restore this alignment. So they're diaphyseal bones, but the shafts have to be lined up appropriately to restore the joint. The axis is long, it's easy. The ulnar head to the radial head. So it's an oblique axis, the axis of rotation. So it's from the fovea of the ulna to the radial head. And the ulna is somewhat stationary, but it moves and it's straight, kinda, but not, not completely, but it's the straighter bone. And you think about the olecranon is the posterior aspect of the ulna, and that goes distally longitudinally to the ulnar styloid. So that's the posterior aspect of the ulna, and then the radial head rotates, and the radius rotates around the ulna. So that's important. So, and then this forearm axis, there's several joints, right? It's very complicated. There's the humeral ulnar joint, which is critical. There's a radiocapitellar joint that's somewhat expendable sometimes, but that's got to be lined up well. Radiocarpal joint, DRUJ, PRUJ, and then the interosseous membrane with the central band. So it's very complicated. Essex Lopresti is a combined injury, as we know, of common fracture of the radial head and disruption of the interosseous membrane and the DRUJ, which would cause acute proximal migration, but it's subsequent, it could be subsequent chronic migration. So Peter Murray causes the unhappy triad of the elbow and of the forearm, and it's a problem. So it can be clear, but it also can be, you know, subtle. This is a radial head fracture, and these are slides I think that Chuck Cassidy shared with me. And, you know, the radial head fracture looks kind of bad, but the key is that this radial shaft is going proximally. So, you know, this is bad, but it's worse is distally. So the radial shaft is migrating proximally, and the DRUJ is off because the injury goes through here, and that's a big problem, right? So the radial head can be subtle, like this one is an angled radial head fracture. You say, well, it's just radial head, but how much does it migrate proximally? And this is migrated more proximally than we can appreciate. And sometimes humeral ulnar joint is off a little bit, but it's angled, but it's more proximal, and it's actually out, the shaft is out radially somewhat. So make sure that we look at the wrist. So this is the normal wrist on the right, and on the left is the affected wrist. So the important thing is the radial shaft is migrated proximally, and that's a problem. So we fix the radial head anatomically, and it's not the radial head is not orthogonal to the radial neck. So there's an angle to it. So if you put your plate on it, and it's parallel to the radial head surface, it's not going to be parallel to the shaft, but that's normal. And then evaluate the DRUJ. And sometimes we need to pin it. If I pin it, I'll make these pins even come out the radial side a little bit, because if they break, then you can get them from the other side. So this is a gunshot wound case of mine, a comminuted radial shaft. So it's kind of a longitudinal instability case, and a ulnar neck fracture. So we need to get this forearm axis lined up. So this is an older case. So this is a tough plate to fracture to find the plate for. So this is an old mandibular plate that's locking a 2-4. Now I think the midfoot set has a long T plate that I use, but you want to span this comminuted fracture. And with this case, this is one of the few cases I'll do a Thompson. So you still need to know how to do a Thompson. There was actually gunshot wound was through here. And remember, the posterior osseous nerve is up in there. So keep that out of the way. Go posterior, make sure the nerve is anterior, and you take it with the supinator anteriorly. Line up the distal ulna, and then you, with a locking plate, you can use a blade plate or a locking T plate. And the axis is lined up. The combination heals non-anatomic, but the radial capitellar joints lined up okay. The DRUJ is lined up okay. And you have a good forearm axis. So if the radial head is not reduced, what's going on? It's either the ulna is malreduced, which if you have a montasia, that's what it is 90% of the time. And you got to worry about that, the posterior aspect of the ulna, it should be straight, but there's a PUDA, the proximal ulnar diaphyseal angle, that gives it a little bit of an angle that Graham King described, that we have to make sure that is similar to the other side. So if the radial head is not reduced, it could be the ulna, or it could be an Essex Lopresti, or sometimes there's an annular ligament interposed, or the LCL can be torn. So this is a case of mine that we actually wrote up. This is a strange case, proximal third radial shaft, the radial head is out. And usually when you line up the radial shaft, the radial capitellar joint lines up okay. But this one did not. So I plated the radius. I thought I did a pretty good job, did a bunch of interfrag screws, but something was still wrong with this radiocapitellar joint, right? It just didn't look right. So I looked at it and fluoroed it and pushed on it, but it didn't seem right. So I finally bit the bullet and opened it up, and the LCL was torn completely and the annular ligament was flipped in there. So we repaired that, and it lined up the radiocapitellar joint better. And it actually, when I looked at the other side, he has a similar strange radiocapitellar joint, but this is his normal. And if this is interesting, if you look at this radial bow is restored, but if you put a straight plate on correctly that's long, it actually hangs off the bone a little bit, which is okay. And talking about the radiographic views, it's important to understand the lateral of the elbow, the AP of the wrist, but it's also the rotation. So this is a zero rotation forearm view. right? Because the ulnar styloid is opposite the radial styloid. So it's a zero rotation view. So it's a lateral of the forearm and a lateral of the elbow. And it's really, you know, lateral or PA or AP of the forearm, but it's the rotation that matters. So if I'm looking at a variance, I make sure I have a zero rotation view of the wrist and forearm of both sides. So radial bow, it's important. You see, this case doesn't have much radial bow, but again, the radial tuberosity is opposite the biceps tuberosity. All right, so here's another case, and this is a case that a complex case that Marco Rizzo shared with me. So a 47-year-old right-hand dominant male, left elbow and wrist pain. In 81, back in the day, radial head fracture was treated by excision and silastic radial head replacement. That didn't work out. 99 resection of the fragmented silastic radial head, increasing wrist and elbow pain. So elbow flexion extension is pretty good. Supination, pronation limited, but symmetric, diffusely tender, and really pain. DRUJ pain and also elbow pain. So this is the elbow, and you see the radial head's gone, and has it migrated proximally? Maybe. You know, what I look at critically is this humeral ulnar joint, and is it parallel? And Graham King taught us this as well. The whole thing doesn't have to be parallel, but usually, if anything, the lateral side is a little bit gapped compared, but the medial half of the humeral ulnar joint has to be parallel. So this is, you know, perhaps a little narrower on the central portion of that medial ulnar humeral joint. And it is because the radial shaft is migrated proximally, and we are in valgus a little bit, right? So look at the wrist, and yeah, indeed, the radial shaft is migrated proximally, and you have some arthrosis because it's a chronic situation. So this is a difficult situation. So what do? We want to line up the shaft, but we have arthrosis. So Marco got a CT scan, there's arthrosis. So we probably can't pull this ulna down, distal ulnar head into the DRUJ and line it up because of that arthrosis. So it's chronic Essex-Lopresti, silastic synovitis, ulnar impaction. And what do? So Marco replaced the radial head at the index procedure, and usually can replace it. And if you look closely, that humeral ulnar joint is parallel now, right? So he's restored that elbow biomechanics at the elbow joint, but then he waited later to fix replace the distal ulna and did a distal ulnar replacement after this is aligned and you have better alignment of the DRUJ. So difficult case, and one of the few cases we'll use an ulnar head replacement. A little more complex. So chronic. So we want to address these things acutely so we don't get chronic cases. So chronic Essex-Lopresti injury is a difficult case, and one of my old mentors, Diego Fernandez, shared these slides with me. So acute stage is longitudinal instability. Chronic stage is you get a contracture because you can't supinate for many years, and you get a contracture. So what happens? So again, PRUJ incongruity. After the radial head is excised and your PRUJ is incongruous, so you have difficulty rotation, and your DRUJ is not aligned properly. So pronation, contracture, limited supination. So this is a case where the whole forearm axis is off, and Diego's technique is to, you know, what do you have to do? And it's a little tricky because you kind of, you know, chase your tail. If your radial shaft is shortened and you push it out and replace the radial head, you oftentimes cannot get it all the way out and get your DRUJ to be lined up. So you need to shorten the ulna and make it anatomic and then replace the radial head. And if there's a chronic contracture, you might need to release a portion of the interosseous membrane and try to maintain that central band, and also release the DRUJ capsule. So a single extensile posterolateral approach between the anconeus and the ECU proximally, get to the radial head, ECU, FCU, mid-shaft to get to the interosseous membrane, and get to the DRUJ. You can do it in all one, you know, really, really big incision to release it. This is a case of 37-year-old machinist, 6 months post-radial head excision. And you don't want to do this. A 37-year-old, you take out his radial head. If he's a machinist, you fix it if you can. I think it's important to fix it or replace it. So problems at his elbow, his humeral ulnar joint doesn't look too bad, but his wrist, his radial shaft is shortened, lacks supination. Diego did a Judet prosthesis at the ulna, at the proximal ulna, and ulnar shortening, and the DRUJ is lined up perfectly as Diego always does. So excellent result. And, you know, effectively the forearm is shortened, but that's fine because it's congruent and it's balanced now. So excellent result with restoration of the supination. So I just want to say this: when is it safe to excise the radial head? When I was a resident, we did it all the time because it didn't, you know, nobody thought it mattered, and then we realized it did. So the answer is rarely, right? So rarely. So this is the last case I did excise the radial head, and I just want to show you the points that you have to really, you know, look at if you decide to do that. So, which is, again, unusual. 38-year-old female, motor vehicle accident, closed radial head fracture. She came to our ER and then she didn't follow up. So this was her in the ER, radial head fracture. And, you know, I would worry about, is it proximally migrated a little bit? Probably not, because the humeral ulnar joint looks okay. But these are a little bit tricky, these radial head fractures, but, you know, fix them, you know, open it up, I do a Kaplan approach. Fix it, take your time. And I try to do just screws on these, headless screws or headed screws, and catch the shaft, because I think without a plate, they do better. But if you need a little plate, you can put that on there. And a 37-year-old, I'd really try to fix it. So, but she disappeared. 9 months, came back, and now she's got a decreased motion and pain, and it looks like a malunion. So my plan was to open it up and try to address it. So this is her motion in the OR, and her flexion extensions. Okay, pronation doesn't look bad. This is her supination, and it looks pretty good, but this is my resident supinating, and it's at the hand, you get fooled, and you can actually see her ulnar styloid right here. So it looks like she's got 45 degrees of supination, but this is me looking at it, and from ulnar styloid to radial styloid, she's got nothing really, like 10 degrees mainly. So really look at the forearm, not the wrist and the hand. So we opened this up with a Kaplan, and I had intentions of doing an intra-articular osteotomy if the joint was okay, but she had a ton of arthrosis, not replaced or not repairable. So now I have this defect there, and it's a chronic situation. So she's got, you know, she's scarred in, so that radial shaft doesn't come out laterally easy, and you can replace it, but she was very stable. So if you decide not to replace it for some reason, or you don't have one, you know, what do you have to check? So I think it's important to realize what the radial head does. So valgus instability. So pronate the forearm and valgus the forearm, and make sure that humeral ulnar joint doesn't open up. Varus posterolateral instability, to make sure when you supinate varus and valgus load, supinate valgus and axial load, it doesn't roll out the back, and you look at the lateral as well. And progressive extension, as you extend the elbow, make sure there's no subluxation, because if there's a little coronoid defect with a radial head defect, you might pop out the back. And if any of these things happen, you have to replace it. And look at the wrist, the DRUJ, to make sure there's no Essex lopresti. It looks normal, and I got an X-ray on the other side. And then load the wrist, so you're pushing on the hand, the wrist, and the radius, make sure it doesn't come back. And Dave Ruch talks about grabbing the radial shaft in the elbow and pulling down on it, and make sure that doesn't make the DRUJ incongruous. So her range of motion was fairly stable, and she's very low demand, not a machinist, not a heavy worker, so we decided to leave it out, and she did reasonably well. So in conclusion, preserve the radial head at the index procedure, or repair it, repair it or replace it. Acute restoration of the forearm axis is critical, acutely, and the ligament healing may never be complete. So, if you replace a radial head, don't take it out just because sometimes I've seen people take it out after 3 years and the whole radius still comes proximally. So that ligament is very hard to heal, and chronic reconstruction is more difficult. Thank you.
Awesome, John. Thank you so much. Some of those x-rays are amazing. They look really great. Do you ever do any kind of interosseous membrane, or have you ever had to do any actual interosseous membrane repair or grafting or anything like that?
Yeah, that's a very tricky a very tricky case. I haven't had good results. I've done a couple of the FCRs and the bone ligament bone, and I have not had great success with it. So I think it's, I think we haven't had that sorted out, sorted that out. And, the guys from Philly have described it, and, they have decent results, but it's hard to replicate that.
Yeah, it sounds like a nightmare. Coming from a trauma surgeon, that sounds like a horrible thing to do. So we actually had some great questions while you guys were talking. So I want to just open this up to kind of all the faculty, but there are some excellent questions, I think mostly related to the first two talks about, order of fixation. If you're doing, for example, a malunion takedown, are you taking down both bones at the same time? Are you fixing one bone preferentially before the other bone? Or do you, how do you guys approach it? And we'll start, sort of with Jen and Tony, and then anybody else who wants to weigh in with pearls of wisdom. Let us know how you guys do it.
Okay, so I'll start. I excuse me, I always for non-union work take down the non-union at both bones, especially, even just looking at the x-ray that you have up. I mean, you're never going to get this thing to move if one of the bones is still stuck. And a lot of times, even with these big giant gaps, these scar tissue and the fibrous tissue around the bones is so dense and so stiff that you really can't get your correction. You can't get length. And it gives you weird rotational stuff going on too, because typically one of the bones is pulled into the inner osseous membrane. And so then you need to free that up in order to mobilize it. So, I get them both mobilized, and it's like the opposite of what you tell, I'm always yelling at the residents for stripping too much when they're doing fracture work. But when we do non-union work, I'm always like, you have to strip everything. You need to be circumferentially around these bones and free everything up before you even think about trying to do any correction.
Yeah, I agree. Same thing with a malunion. I mean, you need to expose them and do if you're going to osteotomize, do your osteotomies on both. And then even then I kind of work back and forth between the two bones. I might do some provisional fixation before I buy anything with my large plates, just to make sure that I love it.
Great. All right. Well, so I've been trying to put this off, but let's get back to this little tasty treat. I think Tony said something in her lecture about all the non-unions being infected, but what do you guys think? Do you think this is infected?
Yep.
Yes.
Yeah, so I was a little concerned it was infected too. And it was interesting actually, because, I had examined the patient, his skin looked intact. We were chatting for a while and he was like, yeah, it's annoying. I can't use it. It's bent, it hurts. And it kept like draining that fluid for 4 months, and it just stopped like a month and a half ago. Right, draining that fluid. He didn't mention that. So anyway, so we're going to assume this is infected too. And so how do you guys sort of go forth, or how do you think about steps going forth, even just get started here? What would you do first? Maybe John.
Well, yeah, in regards to the infection, I think you have to treat them all as infected, and as you just said, because the problem is you do a great reconstruction, and even if everything is negative and then they pus out again and you burn that last case. And I've had cases, and I've talked to prominent trauma surgeons and said, what do you think of humeral non-unions that look okay? CRP's negative, everything's negative, and they do a great case, and 6 months later it gets infected again. So I think you have to stage it. So, and do cement plates or, masculate. So I think there's two things to look at. So first of all, this looks fraught with problems. These two little plates on the ulna, look like they were hanging on for dear life, and they didn't make it. And the radius plate is short. So I think you have to, look at eradicating the infection. So do your studies, get some scans, and, treat it as infected. And then how do you fix the biomechanics of it? And this one's, pretty straightforward. The more distal it is, the easier. So I get good x-rays of the other side, exactly the same. And I think you have to span the ulna, and you have, and it's, you know, it's always how much bone do you have on either side. So after we deal with the infection, and we can, you know, I would stage it. I would put an antibiotic cement in there, take cultures, wait 6 weeks, and come back. And then you want to try to get it as good as you can with those plates or that technique. And I would do some plates I wouldn't do. And those plates don't have to have all the screws in them, you know, because you don't want to burn your holes. And then I would go back and how much bone do you have? You know, the radius, you have a lot of bone distally, and you can do the, you know, I think Tony showed her case. You can do a long, hybrid plate to get to the distal radial metaphysis and bring it down proximally. And that's an easy Henry approach. And then the ulna. So I would make it look like the other side. So again, take out the bad bone, get down to decent bone, put your antibiotics in, provisional plates, and then come back in 6 weeks. And it depends. Sometimes you go in there and there's a big hole and you got to do Sequelae.
Can I inject some stuff in this?
Absolutely.
Only because at Jackson, when I came out of Harborview in the 70s and early 80s, and of course, in a temperate climate, you can close wounds, you can do all kinds of interesting stuff. I get down here to the subtropics, and of course, my chief is Bill Burkhalter, who did an awful lot of work in Vietnam. And we're also dealing with a population that can't always get back into us. So the way that I would attack that is with the Vietnam kind of attitude. Take the plates out, debride everything, culture it, because even with all your tests and everything ahead of time, you still end up getting in there and going, oops, I thought it wasn't going to be infected. It is infected. So I always warn patients, expect for us not to complete the reconstruction this first time out. We're going to open it up. We're going to clean everything out. But by the way, I'm not going to close the wounds. And I don't use methyl methacrylate and all the rest of the newer things that we've been doing, trying to close wounds. Vietnam and Jackson taught me, leave it open. Don't get uptight. Leave it open, let it drain. So we'll do soap and water washes, have a splint. I keep them in the hospital that 10 days because most people don't really want to cope with that open wound. And then bring them back at somewhere between 10 and 14 days. At that point, the wound is usually clean. You might have taken them back for 1 or 2 more debridements. It doesn't matter. But at that point, I'll then do the reconstruction. Plates, just like John was describing, identical. Plates, by the way, with that hypertrophic non-union there, and some of that bone looks like it might even be avascular. Does it hurt for you to cut out 2 inches of bone in a forearm? No, it does not. You will function just fine. So clean up the edges, square them up, and then match the 2 sides and get the bow. And then leave the wound open. It might take a month, 6 weeks to close. It's okay. Soap and water washes, antibiotics, it will heal up. And then you don't have all the infection. And for me, because I'm doing it at a distance, I'm taking care of people that are coming up from South America. I can't have them come in every other week. They can't. They're going back to Ecuador. They're going back to Peru, wherever they're going. But I can leave these wounds open and let them heal secondarily. So don't be afraid of that. Okay, it works well in a wartime setting.
Yeah, my trauma clinic, I think, is a wartime setting. I think that's a perfect analogy, actually. So while we were getting this patient scheduled for surgery to do exactly what you guys all said, which is take out hardware, debride any dead bone, and stage this in some way, shape, or form, we did a little more digging. We got a little more information from, days past. Sorry. And this was the original injury, so relatively simple, and this was the original fixation construct. And I think one of the things that a couple of people have said, and also a couple of people from the audience have asked, really smart questions about is, what is the downside of going a little bit bigger with plates? What is the real benefit of doing tiny little plates on the forearm, and especially in a prisoner? And so do you guys want to weigh in on that? And I'll show you a little bit more what we did next.
Yeah, I want to weigh in. I do not understand what is happening now. I mean, I lived through plates that were straight and we had to bend them and make them fit. And we thought pre-contoured plates were the best thing that ever existed. Or, you know, you knew how to use a DCP to get your compression, whatever. And, you know, we lived through people trying to put 1/3 tubular and recon plates on forearms, and you knew exactly what the next x-ray was going to look like. And then now all of a sudden, everyone is back to putting tiny little plates on things and putting like 20 little plates on. It's like, just put on one big plate that fits. So I do not understand what is happening, because it was really painful to contour and bend your own plates. And if someone's going to make a plate that fits a bone, not necessarily for a forearm, but for other bones, I'm doing it. But I'm not, you know, again, I mean, that's one of the benefits of being old, is that I lived through all of these mistakes already. I don't have to make them again. I'm not putting a small plate on a radius or an ulna.
Yeah, my residents make fun of me all the time, because whenever I let them choose the plate, they're like, you know, how much too short is this plate? And that's because my philosophy is there's no plate that's too long. There's just 6 plates that are too short that you could have not put in. So just in the in terms of time, I'm just going to move forward and show you guys kind of where we went with this. So I took him to the operating room and took out all the hardware, took some bone cultures, debrided some of the bone, left some of the bone for next time. And he actually was extremely well vascularized, which I was really happy about. All that bone that was in there was bleeding like gangbusters. So he didn't have a ton of dead bone, even though he has a lot of hypertrophic bone in here. But I think this is sort of where he was. I ended up putting pins and antibiotic kind of spacers in and around here, which I don't have the pictures of. But is there anything that you're seeing on these pictures that makes you guys really sad?
The DRUJ makes me sad.
Yeah.
Yeah, that made me sad too.
Yeah, I made that mistake already. So now I focus on that a lot more. I think then, you know, it's never as good as you think it is. And you also have to, you know, to get back to the thing that Jen was talking about with the x-rays, you got to be really careful about what views you're getting in the operating room, because you're getting, if you're on a hand table, you're getting the exact opposite of what the views are that you should be getting. And so you're never truly looking at your DRUJ correctly. And I think that's, you know, that's what has happened to me on more than one occasion, shall we say.
Yeah, and I think once I had these pictures, I sort of really realized how short the radius is, how much bone we're actually missing from the radius compared to the ulna. And it's a pretty good stretch. So we're about to run out of time here. I want to leave just a minute or two for extra questions from the audience if there are any, but I'll just show you guys sort of what I did. And so contralateral views in the operating room, and then I believe what a couple people have also said is I just did a shortening. So I shortened the radius. I sort of got as much bow back as we can, or that I could, and did a compression plate across the radius, and then I shortened the ulna about 1.5 centimeters so that he wasn't so ulnar positive anymore. So he does have a shortened forearm, but he has a forearm that's mostly healed and that is not painful. This bone here is actually some of the healing in the radius, which is great. This little gap is on the ulna still. And so he did a lot better than I expected. I always expect the worst. And I think, you know, the pictures are just sort of what everybody talked about, you know, getting in there, getting some kind of contralateral views, recognizing if you have a problem at the DRUJ and with length, trying to restore your bow, and then also making sure that you have good plates and good support, and trying to grow some bone back. So we just have a couple more minutes before we get kicked off the internet, but are there any questions that are outstanding from the audience? You can throw those into Q&A, or any other comments from the panel if you guys want to bring anything up.
Yeah, I actually just wanted to comment on those long metadiaphyseal plates for the radius. I find those to be really helpful in situations like this, because they can help you get your bow correct. Like John mentioned at one point that if you are using a straight plate on the radius, it actually should not be centered on the bone like some of my x-rays were. It should be hanging off the side. But I find these plates can help you to recreate that, because, you know, visually it looks like where you think the plate should be sitting. So I like these for these cases that go quite metaphyseal.
Yeah, no, I like him for a dumb trauma surgeon because then it already shows me where the bow needs to go back to. And most people, I don't actually have to figure it out. I just have to put the plate there, which I think is helpful. And it has some more distal fixation if you're running out of bone or if you have old screw holes. And it's also a really big, beefy plate. So that's quite, this particular one's a big stocky plate, which I like my prisoners to have stocky hardware if they can.
Mm-hmm.
There was a question about the approach on that, Chris.
Yeah, no, I just so I went back through his prior approaches. So he just has like a regular Volar Henry approach, and then it's just a direct approach to the distal ulna.
And you did your fixation of the radius before you decided how much to shorten the ulna?
Exactly. So I put the radius back. I debrided radius back to healthy bone, and then I compressed through that, and then I figured out where the ulna needed to be. You know, it just took me like 4 cuts, but I figured out kind of where the ulnar needed to be to match the DRUJ on the contralateral side.
Nice.
Yeah, there was a question about the DRUJ. What do you need to do to make sure that it's stable after an ulnar shortenings? I'm not smart enough to do ulnar shortening, so I just keep cranking on the radius and make it longer.
Yeah, and in this case, I think his DRUJ it ended up being great. It was fine. There was no instability there at all that I could tell afterwards. And I think it's a great question, especially in a case like this. It's a little bit, tiny bit off topic, but when all the soft tissues are messed up, he had, such a big deformity. So all of his, dorsal structures are stretched, all of his volar structures are contracted. And so it's a little bit hard to tell soft tissue balance wise where you are in a lot of different places. And so I'll just do what I would do for an acute DRUJ and just do sort of like a little shuck test compared to the other side, and stress it a little bit. Just making sure we have all of our questions answered. I think.
Last one was about fixation of the ulna. Do you need to use a 3-5 plate if you're running out of room distally?
So there's actually lots of super cute ways to fix the ulna distally, but I don't put anything smaller than a 3-5 plate on prisoners or very active people, or young men with huge forearms and lots of muscle and poor decision-making ability. And so I just think, go big or go home.
Yeah, very distally, I'll use a 2.7 DCP, but not any other plate besides a DCP. Anything else is just too wimpy. And even then, only again for smaller people, but not for some big beefy person or a prisoner.
As it gets more distal, you can even put the plate on the subcutaneous border on the straight ulnar border and go into the head and put multiple lock screws into the head. And they kind of hate that plate, but if it's just a neck or it's a distal fracture, you need that for fixation. You take it out later. Christina, why did you do the radial, the dual plating on the radius? I think it makes sense, but maybe you can comment on that.
Yeah, no, so I did that one for a couple of different reasons. I had put a little extra bone graft over there, and so I kind of tucked that bone graft into that side plate, but I often will do this, and this is a beefier plate than I would usually use for this. Usually I'll use like a little 2.0 plate or something to kind of reconstruct the radial bow when there's a lot of comminution on that bowed side, because I think even if you if you're missing bone on that side, if you had like a little butterfly fragment that came out in an open fracture or something, I'll put that little bend in just to kind of get the curve back, basically, and to hold any bone graft that you want to put in there. And I think we have to go, actually. I think we have to wrap up. So I just want to thank all of our speakers so much for joining us. Thank our audience for being here. You guys were great. It was a wonderful discussion. And I think I learned a lot personally. So hopefully you guys did too. And don't forget to check out those AO resources that we put up at the start and our YouTube channel.